Hi everyone, in this video we'll be discussing some of the important infections and the drug of choice. Now, when we studied in the previous video, we understood the drugs, mechanism of action and where they are drug of choice, but we are not getting all the infection at one point of time, at one place. So the purpose of the video is to tell you that what are the important infections and what are the drug of choice which are frequently asked in your exams, and that is what we are going to discuss here. So let us start our journey, important infections and drug of choice. Nowadays, the questions are framed in such a way that they will give you the symptoms, they will give you the diagnostic test, and they will ask you what is the diagnosis and then the treatment. So that's the reason when we have infection and drug of choice together, it's easy to revise. So let us start our journey, important infections and drug of choice. So before we start, let me tell you there are certain drugs which are safe in pregnancy. What are the drugs safe in pregnancy? The mnemonic is PCM. So any infection in pregnancy, these antibacterial drugs are safer. P for penicillin, C for the cephalosporin, and M for macrolide. Now, which are avoided or contraindicated in pregnancy? Very, very important. The fluoroquinolones because they can cause cartilage damage. Aminoglycosides because they can cause ototoxicity. Tetracyclines because they can cause teeth discoloration and bone damage. So they are not at all given in pregnancy. Moving on to the second infection, typhoid. Very common in India, typhoid fever, not only in India, across the world. Salmonella typhi. And the drug of choice for that is ceftriaxone. It is called as ceftriaxone. The name is ceftriaxone, but here we have carriers for that. For typhoid carriers, what we can give for typhoid carriers, the drug of choice is ciprofloxacin. That is the drug of choice for typhoid carriers. Now moving on to the next one, atypical pneumonia. There are bacteria called chlamydia, mycoplasma legionella. They are known to cause pneumonia. And the best drug which can cover all this and the macrolide drug is azithromycin. In one of your recent exams, they had asked a question. When you are treating community-acquired pneumonia, why do you combine beta-lactam with macrolide? The reason is beta-lactams will not kill the chlamydia, mycoplasma or legionella. The reason mycoplasma, because mycoplasma doesn't have cell wall. So these drugs act on cell wall, that is beta-lactam, so they cannot kill them. That's why in community-acquired pneumonia, along with beta-lactams, we have to add macrolide. So azithromycin can cover atypical pneumonia, and that is a drug of choice. Pseudomembranous colitis is caused by a bacteria called Clostridium difficile. And the drug of choice for that is oral fidaxomicin. If that is not in the option, you can check oral vancomycin can also be used. So this is the recent update. The first choice is oral fidaxomicin. That is the first choice. Let us understand pseudomembranous colitis. Very, very important. Pseudomembranous colitis is caused by the bacteria called Clostridium difficile. Now it is a super infection. What do you mean by super infection? When you give some antibacterial drugs or antibiotics, they will kill our normal flora. When you kill the normal flora, the pathological bacteria will proliferate and cause the infection in the GIT, leading to diarrhea. So here the pathological bacteria that proliferate is Clostridium difficile. And what is the causative? What is the causative antimicrobials? So causative agents are what? The causative agents which are known to produce this problem, that is pseudomembranous colitis, are the third generation cephalosporins. These are most commonly used, and that's the reason why they are most common cause of that condition. Second important group of drugs which are known to produce that, they are called as clindamycin. So the group is lincosamide, the drug is called clindamycin, and clindamycin is considered as most potent drug to cause this problem. Apart from that, the fluoroquinolones like ciprofloxacin, ofloxacin, then the aminopenicillins. What are the aminopenicillin? Amoxicillin and ampicillin, they are known to produce this problem. Now that is a causative agent. So recently they had given a question, clindamycin was used for treatment. A patient came with diarrhea. How do you manage this? So the treatment for this condition, I told you, the drug of choice is oral fidaxomicin. So if it is not available, the other options are oral vancomycin or oral metronidazole, or one more option what we have is oral rifaximin. This is the order of preference. First is fidaxomicin, then vancomycin, metronidazole, and rifaximin. Another important problem is this will recur again and again. So there are drugs to prevent recurrence of this. Infection. For that we use a monoclonal antibody. The monoclonal antibody is called bezlotoxumab. So bezlotoxumab is a mAb against toxin B produced by the Clostridium difficile. So this is a mAb against toxin B, that is called bezlotoxumab, and remember this is a FDA approved drug for recurrence. Now one more drug which is not approved, FDA approved, it is called acetoxumab. It is against toxin A. Remember it starts with A and it has tox in the name, again toxin A. Bezlotoxumab starts with B, tox in the name, so it is against toxin B. It is still not FDA approved. So this is to prevent recurrence of infection. That is about the management of pseudomembranous colitis, repeatedly asked in your exams. Okay? Yes. Let me move back. Now, skin infection caused by methicillin sensitive staph aureus, MSSA. For this, what we use, methicillin sensitive staph aureus, is a combination of amoxicillin plus clavulanic acid. Now, why we cannot give amoxicillin alone? Because amoxicillin can be cut by the penicillin produced by staph aureus. Otherwise, if that is not there, you can use dicloxacillin. Dicloxacillin is called as anti-staphylococcal penicillin, or it is also called as penicillase resistant penicillin that can be used. So recently that question had been appeared in the exam. A lady came with breast abscess. What is breast abscess? Skin infection, and it's a skin and skin structure infection, usually caused by staph aureus. So for that, the treatment is dicloxacillin because it is anti-staphylococcal penicillin. If it is not there, you can give amoxicillin plus clavulanic acid. Now, the infection, staph infection, became resistant to methicillin. So MRSA, the drug of choice is vancomycin. Now, another important thing is for MRSA carriers. For MRSA carriers, usually they are nasal carriers. Let me write that also. Nasal carriers, the preferred one is mupirocin. If that is not available, you can use a drug called bacitracin can be used. Mupirocin or bacitracin can be used. Now VRSA, which is called vancomycin resistant staph aureus, the drug of choice is daptomycin. Now the problem is daptomycin is inactivated by the lung surfactant, so we cannot use it in pneumonia. So suppose there is VRSA pneumonia, then the drug of choice will be linezolid. The drug of choice is linezolid. So staph aureus is one of the favorite question for the examiner. The question keeps on coming against the MRSA infection. So let us understand this. Let me take one more slide and tell you about this. MRSA. Okay, so the nasal carriers, you know what to do. Nasal carriers, you have to use either mupirocin or bezitracin. The drug of choice for MRSA is vancomycin. MRSA beta-lactams are ineffective. Except fifth generation cephalosporins. Okay, the fifth generation cephalosporins like ceftobiprole and ceftaroline. Now, apart from this, is there any other drug used for MRSA? What are the other drugs? Let me write nasal carrier also. It will be easier when you revise. Mupirocin and bezitracin are for topical application for nasal carriers. Now, the drug of choice is vancomycin. The ineffective drugs are beta-lactams, very commonly asked. You can use streptogramins. You can use linezolid. You can use daptomycin. And you can use rifampicin. Then tetracyclines. Then tigecycline. And in fluoroquinolone, there is a drug called delafloxacin. So these are very, very effective for managing MRSA. Streptogamins, linezolid, daptomycin, rifampicin, tetracycline, tigecycline, and delafloxacin. Now, the problem is, should we remember all the drug? No need. Remember this concept. Remember, drug of choice is vancomycin, carriers, these are the drug of choice, and beta-lactams are ineffective except fifth generation. Suppose a patient develops VRSA. So VRSA, what are the options we have? VRSA, we have daptomycin. So that is a drug of choice for VRSA. Now linezolid is one more option. Linezolid is preferred in VRSA pneumonia. And importantly, streptogramins. Right, so that is about MRSA, and they can ask you the reason for MRSA. It is because of altered penicillin binding protein. That's why beta-lactams will not work on that. Okay, so once we know about the MRSA, then VRSA, and all these things, let us move on and discuss the other drug of choices here. Let us discuss other drug of choice. Pseudomonas. Now, Pseudomonas is very common in hospital. It's one of the hospital-acquired infections, pneumonia, UTI, then burns infection. So the drug of choice is a combination of ceftazidime plus an aminoglycoside. Usually the aminoglycoside which is given is gentamicin. So it is used in combination therapy. Why combination therapy? We don't want the drug to become resistant. So let me do one thing. I'll discuss what are the drugs effective for Pseudomonas, and majority of questions come from here. So let me write the anti-pseudomonal drug. Anti-pseudomonal drugs. So let us search from the cell wall. In cell wall synthesis, penicillins. Do we have penicillins? Yes. Penicillins, we have anti-pseudomonal penicillin. What are those? The carboxypenicillin, like carbenicillin and ticarcillin. Then we have uropenicillin. We have the MAP, methicillin, azoxystrobin, but mainly remember what we use in practice is piperacillin. So the mnemonic is CT-MAP, and all the drugs can work on Pseudomonas. Will amoxicillin work on Pseudomonas? No. Ampicillin? No. So penicillins, these are the things. Now coming to cell wall, one more group, cephalosporins. In cephalosporins, remember the major effect is seen with the third generation cephalosporins. In third generation cephalosporins, two important drugs, cefoperazone. So cefoperazone and a drug called ceftazidime. So remember, these drugs end with Z. Usually they have activity, and I just told you this is the drug of choice for the Pseudomonas. See, combined with aminoglycosides. Yes, so that is third generation. Now moving on to the fourth generation. The four generations are also effective: cefepime and cefpirone. Cefepime and cefpirone. Fifth generation, only one drug is effective. The name is ceftobiprole. Why ceftobiprole? Because ceftobiprole has same gram negative coverage like ceftazidime. Now, one drug which has the feature of third and fourth generation, which has the feature of third and fourth generation, which has come to the market, it is called cefiderocol. It is called cefiderocol. That is also effective on Pseudomonas. One more drug which is derivative of ceftazidime, it is called ceftolozane. It is called ceftolozane, and ceftolozane is combined with tazobactam. It is combined with tazobactam. Okay, sir, should we remember all these things? Not necessary. Remember the drugs ending with Z, and third generation and fourth are going to effective, and fifth generation ceftobiprole, because ceftobiprole has same gram negative coverage like ceftazidime, and the drug which has third and fourth generation properties, cefiderocol, and derivative of ceftazidime, that is called ceftolozane, and combined with tazobactam, they are effective. Now the question is ceftriaxone effective on Pseudomonas? No. Then moving on to the other cell wall drugs. What are the other cell wall drugs? The carbapenems. Yes, carbapenems going to work on Pseudomonas except ertapenem. Ertapenem doesn't have very good coverage on Pseudomonas. Again, another beta-lactam. What is the name? Monobactam. Yes, aztreonam will also work on Pseudomonas. So I told you penicillins what are important. Then I told you cephalosporins, and then carbapenems, aztreonam will work. The question is, will vancomycin work in Pseudomonas? Yes or no? Please pause the video and tell me. Will vancomycin work on Pseudomonas? Yes or no? No. The reason is it works only on gram positive only, and Pseudomonas is gram negative. Okay, so what about cell membrane, sir? In cell membrane, we have polymyxins. So polymyxin B as well as colistin, they can work on Pseudomonas. But where to use them? They are used in resistant cases only. Resistant case of Pseudomonas only we use them, otherwise you don't touch it. Because these are highly neurotoxic and highly nephrotoxic drugs. So we are done with cell wall, we are done with cell membrane. Will daptomycin work? No, daptomycin is only working on gram positive only. Then come to protein synthesis inhibitors. So in protein synthesis inhibitors, the major drug work on Pseudomonas, they are aminoglycosides. So the drugs you can remember as tag drugs, tag for tobramycin. Tobramycin is also given as inhalation route when there is cystic fibrosis with Pseudomonas. A for amikacin and gentamicin. Then any other tetracycline? No, remember tetracycline don't cover Pseudomonas. Then we have another group of drugs. They are called sulfonamides. So before I come to sulfonamides, is there any drug which acts on DNA gyrase? Yes, fluoroquinolones. In fluoroquinolones, only two will cover that: ciprofloxacin, and one more drug is levofloxacin. And sulfonamides will also cover that. So examples for sulfonamide are silver sulfadiazine, which is used in burns patient, so they will work. So I have given the list of drugs which are effective on Pseudomonas, and based on that the questions will come. Why Pseudomonas they will ask in the exam? Why will they ask Pseudomonas? The reason is simple, very common, and it is tend to acquire resistance and very difficult to treat the resistant bacteria. So that's why the question keeps on coming about anti-pseudomonal drugs. Remember, they will ask basically, will the vancomycin work? No. Daptomycin? No. Linezolid? No. So these are the drugs, and the drug of choice is a combination of ceftazidime plus aminotriptyline. So moving back, ESBL producing E. coli or Klebsiella. Now this E. coli and Klebsiella, these are very common hospital-acquired infections. Now what happens when we put a catheter in the bladder? There is a chance from the catheter also the UTI can happen. And these E. coli and Klebsiella, they are acquiring resistance every day. Day by day, they are becoming resistant. So for them, the drug of choice, ESBL stands for extended spectrum beta-lactamase. ESBL stands for extended spectrum beta-lactamase. For them, the drug of choice is carbapenems. If carbapenems are not there in the option, search for a combination of beta-lactam plus beta-lactamase inhibitors. A classical example I give, piperacillin plus tazobactam or a cephalosporin with beta-lactamase inhibitors, they can be used, but never give the beta-lactams alone except carbapenems, because these extended spectrum beta-lactamase can cut penicillin, cephalosporin, monobactam, but it cannot cut carbapenem. That's why they are the drug of choice. Nowadays, even carbapenems are cut by Klebsiella. That is a next problem what we are going to face in the future. So for ESBL producing Klebsiella and E. coli, carbapenems, the beta-lactam plus beta-lactamase inhibitors are the drug of choice. Moving on to meningitis. The empirical drug of choice for meningitis. Empirical drug of choice. Suppose a patient comes with meningitis, we don't know what is the infection. That time we can use ceftriaxone because it covers majority of the bacteria causing meningitis. Suppose if the meningitis is because of listeria meningitis, now that time the ceftriaxone is not useful. Why? Listeria is not killed by cephalosporins. Any cephalosporin will not kill. That time you have to change the treatment to ampicillin. So this is a recently asked question. Empirical drug of choice meningitis, ceftriaxone. Listeria you have to change to ampicillin. Pertussis, diphtheria, even though infections are not common, but there is a chance they can occur, and the drug of choice is erythromycin. It can be used. Rickettsia. Usually rickettsia infections, we don't see them regularly in the practice. So many times to rule out PO, Pyrexia of unknown origin, we have to rule out rickettsia. And the drug of choice for that is doxycycline. Leptospirosis, again the drug of choice is doxycycline. Now enterococci is again a bacteria which is common in hospital, and it is again a resistant bacteria. Lili, fecalis and listeriosis, the drug of choice is ampicillin. Faecium, the drug of choice is vancomycin. Nowadays we are seeing vancomycin resistant enterococci also. Campylobacter jejuni, the drug of choice is a macrolide called azithromycin. The macrolide is azithromycin. These are very, very important. The questions are coming for H. influenza. Now why the H. influenza? The reason is H. influenza can cause the upper respiratory tract infection like otitis media, or the serious infection like epiglottitis, the pneumonia or meningitis like that. Now, what happens if H. influenza? Usually for H. influenza, upper respiratory tract infections, you can use the drug of choice is ampicillin. But nowadays, they have become resistant to ampicillin also. So there are two reasons for ampicillin. The bacteria is producing the enzyme beta-lactamase. So there are two reasons for resistance. Either it is producing an enzyme called beta-lactamase. The H. influenza is producing the enzyme beta-lactamase, or it is having altered penicillin binding protein for ampicillin. So this is called beta-lactamase negative ampicillin resistant case. Ampicillin resistance case. So that's the reason nowadays, if H. influenza is not treated with ampicillin, the drug of choice will be ceftriaxone. So ceftriaxone can be used in ampicillin-resistant cases. So this is a recently asked question for your exam. So ampicillin resistance can be due to beta-lactamase or because of altered penicillin binding protein, and that time the drug of choice will be ceftriaxone. Ceftriaxone is also used in serious infection like H. influenza meningitis, if there is epiglottitis, or if there is bacteremia. Then ceftriaxone becomes a drug of choice. For milder infection, you can give ampicillin, but if you suspect ampicillin resistance, you have to start the patient on ceftriaxone. Recently asked question in your exam. So one more infection we are all excited is the management of anaerobic infections. So whenever we think of anaerobic infection, what anaerobes will come to the picture? Clostridium species, the Bacteroides fragilis, then actinomyces. So these all come to the picture. Now, what are the drugs which are most effective for anaerobes? Two major drugs what we use is metronidazole, and one more is called clindamycin. Now, if I take a picture of a man, a patient, right? So any infection occurring above the diaphragm. So this is the point of diaphragm. So above the diaphragm, any anaerobic infection, what we prefer is clindamycin. Below the diaphragm, what we prefer is metronidazole. Sir, can we use clindamycin below the diaphragm? Yes, you can use it, but the best one is metronidazole. Supradiaphragmatic also you can use metronidazole, but the best one is clindamycin. Sir, why? The reason is clindamycin can cover certain anaerobes like actinomyces. It can cover actinomyces, which is not covered by metronidazole. It can also cover microaerophilic streptococcus. So the coverage is better with clindamycin. So above the diaphragm, that is better. Below the diaphragm, why metronidazole is better? Because the drug clinda, it misses some Bacteroides fragilis, and that is covered by metronidazole. So metronidazole is better for infradiaphragmatic anaerobic infection. Both are used, but better is what I am telling. Yes. Sir, okay, sir. Metronidazole and clindamycin are only two drugs. Are there any other option? Yes, we have other options also. Chloramphenicol can cover anaerobes. Then will the cephalosporin cover? Yes. Cephalosporins also cover. Particularly the second and third generation will cover. Now the frequently asked question in exam is, in cephalosporins, who can cover Bacteroides fragilis? Which can cover Bacteroides fragilis is a question. Now Bacteroides fragilis can be covered by cefamycins. Cefamycin belong to second generation. So in cefamycin we have cefotitan. Then cefoxitin, and one more is cefmetazole. So these are covering this Bacteroides fragilis. This was asked as an MCQ. Now coming to other important aspect, Bacteroides fragilis. Third generation cephalosporin which covers Bacteroides fragilis is cefoperazole. So these are the questions which will come. Then you can see all of them are coming in C, clinda, chloramphenicol, cephalosporin. One more C which will cover that is carbapenems. Carbapenems also cover anaerobes. Then what about vancomycin? Yes, obviously Clostridium is covered. Vancomycin will cover that. Now all beta-lactams, we have discussed beta-lactams like penicillin can cover Clostridium. So beta-lactam plus beta-lactamase inhibitor they can be used. For anaerobes, combination should be used. Sir, what about fluoroquinolones? Fluoroquinolones, mainly remember the major drug which will be effective is moxifloxacin. That will cover the anaerobes. So these are the things. Please remember mainly metronidazole for infradiaphragmatic, clindamycin for supradiaphragmatic, and cephalosporin which cover bacteriophages. I have told you. So I told you when you are treating the patient above the diaphragm, Linda, below the diaphragm, metronidazole. But everywhere, if anaerobic infections, everywhere you want to treat, then what is best is a combination of beta-lactam plus beta-lactamase inhibitor. So that can cover everywhere, below and above the diaphragm. Then carbapenems and moxifloxacin. So these are the important applications of these things. Okay, so we understood the management of anaerobic infections. Now the next important aspect, what they will ask in the exam is prophylactic therapies. They keep on coming and you should be knowing this. Meningococcal meningitis prophylaxis, how do we give it? This is given with the help of ceftriaxone. Ceftriaxone is the best choice because you can give it in children, pregnant, everyone. Then ciprofloxacin. Then rifampicin. RSD, benzathine penicillin, you all know. It is given as every 21 day, 1 IM injection. TB, mainly it is INH. Nowadays, rifampicin, levofloxacin are also used, but the major drug is isoniazid. MAC infection, Mycobacterium avium complex, it is the azithromycin or clarithromycin can be used. Gonorrhea syphilis, ceftriaxone can be used before and immediately after the contact. Recurrent herpes, sir, why are you telling a virus here? So that the revision becomes easier. Every point is at one slide. Malaria, commonly used drugs are doxycycline, mefloquine. Malaria, doxycycline and mefloquine. Influenza, Oselta, Mevir. Cholera, it is tetracycline. Plague, doxycycline. Now we don't have this, so don't worry. But most of your exam question will be on pneumocystitis erosive because it's an opportunistic infection in HIV patients. So the drug of choice is cotrimoxazole. Cotrimoxazole is the drug of choice. Now, if there is outbreak of filariasis, then they will ask you the mass chemoprophylaxis is given with albendazole plus you can add DEC or you can give ivermectin. So this is the prophylaxis for filariasis. Other prophylaxis like HIV and all we have discussed in the same section of HIV. Okay, so these are the major important prophylaxis, and even HIV prophylaxis they will ask you, which we have discussed in the HIV topic. Right. So that is about some of the special points about the bacteria. So we understood some of the important infection and the drug of choice. Some infections I have dealt in detail. The reason for detailing is these are very common and the questions keep on coming from that. I'll just tell you one story about certain bacteria which are very, very common in our hospitals now. These are called as escape pathogens. They are called escape pathogens. Now, what do you mean by escape? Escape pathogens means E for E. coli. So we discussed the treatment of E. coli, which is producing ESBL. Then S stands for Staphylococcus. And that's the reason I went in detail to discuss MRSA, VRS and all. Then Klebsiella pneumoniae. So again, it produces ESBL and it can also cut carbapenem. Then Acinetobacter baumannii, and the drug of choice for that is carbapenems. If there is MDR, multi-drug resistant Acinetobacter, then we are going to use the best drugs, colistin. But the problem with colistin is highly nephrotoxic. Pseudomonas also I dealt in detail. Pseudomonas. And E for enterococci. So it is Enterococcus faecalis and faecium. So please, when you study this in microbiology, keep in mind that these are the potential questions in the exams. The escape pathogens, because these are very common in hospital, they are known to acquire resistance, and there are few drugs to treat them. And the future is to fight this one. The future of medical therapy is to fight these things. So that's why very important, the escape pathogens. Okay, so that is about in this video, important infections and the drug of choice. Thank you all.